what an excellent lecture. Thank you very much, Dr. Mitchell. And now we are starting taking the questions. If anyone has a question, I think Thana Rabi, do you want to ask a question?
Assalamu alaikum. In the first case, the first case, which was annotated as LR5, was there a tumor in vein in the right hepatic vein?
The first case.
Are you saying that very first case with the multinodular mosaic configuration?
No, the one with strike nodular with the nodular appearance was I think it was segment 7. The first
yes,
case.
That image, I could wind back to that. This case.
Yes, this case. Yes, this is the last image. Is there a tumor here? This is a. Is there a thrombus in the right hepatic vein?
Why you're saying that this image would look like that? I think it's just a fake out. The heterogeneous appearance of the liver is such that you can see that there's no sign of hyper enhancement of it. It's not showing up as such on the other images, but it's a good observation. In reading this case, you would need to look at this page up and down and decide it.
Can I do another modality to be sure?
Excuse me?
Can I do another modality to be sure if this is a thrombus or not?
Well, you certainly could if you're.
Because I have doubts.
Yeah, no, I could understand that. In point of fact, looking up and down, the first step is to fully look through all the images. And on this particular level, I could certainly understand why you'd have doubts. The first step is paging up and down through all the images. And if you have it, looking at diffusion. But certainly, if you still have doubt, that would be reasonable to mention that and consider another imaging modality.
Thanks.
So
may I say something?
I have Dr. Mohammed Eid from Alexandria, Egypt. This guy, actually, I have to tell you that I've seen him in one of the courses I given like 10 years ago. He has not missed any single lecture since we have started this webinar. And in Egypt, I know in Alexandria, Egypt, they call him the Messi of radiology. You guys are familiar with Messi? If you're not watching soccer, you will not know Messi, but Messi is like the super champion, superstar in soccer. So, Mohammed, do you have a question? Dr. Eid? Dr. Eid?
Yes.
Can you
hear me?
Yes, very well.
Yes. First of all, I want to thank you all for the great course. It's really wonderful. And my question for Dr. Mitchell, for the LRM observations, the treatment plan states that biopsy is often needed. I'm stressing on the word often. That means that I can figure out what type of LRM lesions that can be managed without biopsy. How can we treat a tumor with unknown final tissue diagnosis?
It's a very good question, and indeed that's why the word was often necessary as maybe necessary. For LI-RADS 4, it may be necessary. LI-RADS M, it may be that the exam might be less than optimal, and let's say on a CT it may look like LI-RADS M. Maybe MRI could help determine if it's really LI-RADS 5. That's one scenario. Another scenario might be the patient is a very poor risk, critically ill, and you have a lesion way up at the dome of the liver that might not be amenable to biopsy. Maybe the patient has an alpha fetoprotein of 2000. there is a high likelihood that that's hepatocellular cancer. Or perhaps CA19-9 is extremely high. That might be another consideration. So there are scenarios where biopsy might not be needed. And I've listed a few of them, and it may be that the radiologist could be unaware of any of those. So that's why we still need to keep in mind that biopsy might not be the best thing for that particular patient.
Okay, thank you. I appreciate it.
Okay, agreed. Thank you very much, Dr. Eid and Dr. Mitchell. Any other question, guys? Claude, do you want to make a comment?
Yes, I wanted to make two comments. Well, three comments. My first comment is Don, what a beautiful, wonderful lecture you gave. Every time you speak, I learn something from you. Well, more than one thing. So thank you very, very much. I wanted to comment on the first comment, the first question. Forgive me, I don't remember her name, but there was a radiologist who wondered about the possibility of tumor in veins in the right hepatic vein. I agree with Dr. Mitchell's response that in this particular case, you have one single image in the portal venous phase or delayed phase where it looks like there might be a tumor in vein. And so as Don was saying, you'd want to go through all the images. If after going through all the images, and this is something that Don said during his lecture, so I'm just simply repeating what he said, but it's an important point. If after seeing all the images, you're worried that there's tumor in vein, but you're not sure, then don't call it an LR-TIV. You'd still call it an LR5, and then you'd say, however, I am concerned about the possibility of tumor in vein, and to evaluate that possibility, I recommend the following test, and the following test may be some other modality. I hope that makes, Don, do you agree with that before I go on to the second comment?
Yeah, absolutely. I completely agree with that.
And then for the second comment, what I'd like to say is that we're very interested within LI-RADS in improving the LI-RADS M category so that we can make the LI-RADS M category more specific and hopefully more sensitive for non-hepatocellular malignancy. So if there's anyone on this webinar who's listening, who's interested in a potential research project, I would say that's a very important one, is to try to improve our definition or criteria for LI-RADS M so that LI-RADS M becomes more and more specific for non-hepatocellular cancer. So my point is that it's a very interesting area for research. If anyone is interested in doing research in this area, please reach out to us in LI-RADS. We'd be happy to try to help you out in designing your research project if possible. Anyway, I just wanted to say that. Thanks.
Thank you, Claude. Victoria, do you want to say something? Dr. Cherniak, is she still here?
I'm here. I love it when you just calling me like this, Khaled. Now, this is a fantastic lecture, Dr. Mitchell. Thank you so much. I have no further questions other than it was just a fantastic lecture.
Okay.
Well, thank you, Victoria, for the kind words.
So we have Dr. Canella from Palermo. Buonasera, Dr. Canella. Do you have a question here? Can you please speak?
Buonasera, everyone. Thank you. Very interesting question. Actually, an interesting lecture. Actually, I have one question regarding the follow-up of LI-RADS 4 lesion. So for this lesion, we usually recommend 3 months follow-up. But my question is, how long should we keep this following up if the lesion does not progress to LI-RADS 5? And for the LI-RADS M, just one consideration, maybe it will be also interesting to look at the ancillary features that lay out for the diagnosis and differentiation of those LI-RADS M observation.
All right, so I'm not sure if I understood the second question, but we'll get to that. But the first question, it's a very good question about the length of time. One general rule of thumb is when you first see something, you don't know how fast it's growing. And that will affect what the interval is. So if you're worried that something may be an aggressive tumor, you will likely not want to wait a long time before imaging it next. So you might recommend imaging in 2 to 3 months. And let's say you repeat it and now it's stable. That's a little reassuring. Let's say you repeat it in another 3 months and it's still stable. At some point, you're realizing that you're dealing with a slow-growing or stable tumor, and you may want to extend your interval. That's a rule of thumb type approach, so you don't necessarily want to keep to the same interval, but it's the uncertainty as you go on with time, you get more confidence that it's not going to get out of control. In fact, at some point, you may get to the situation where you may consider downgrading it to a LI-RADS 3, given that you've now provided additional information that it's relatively stable. I hope, did that get at your question, the first question?
Yes, because we have like some lesion that we experience that they are LI-RADS 4, but we repeat follow-up each 3 months, but the lesion never upgrade to LI-RADS 5.
Right.
So we were thinking sometimes to switch with ultrasound 3 months and then another diagnostic exam repeating after other 3 months.
I think that's a reasonable approach. Additionally, biomarkers can affect that if they're abnormal and increasing, that may tell you something. If there's an urgency to treat, then you may not want to keep waiting to get a definite diagnosis. There are times that LI-RADS 4s proceed directly to treatment. There's nothing in LI-RADS that says that a LI-RADS 4 tumor can't be treated. In fact, there are parts of the world that have considered combining LI-RADS 4 and 5 because they're less reluctant to hold back on treatment. We haven't done that because LI-RADS should be able to apply everywhere in the world. But if a practice is such that LI-RADS 4 is close enough in confidence to merit treatment, that is a treatment option. So LI-RADS 4 are sometimes treated. Or if there's urgency to treat, but a definite diagnosis is needed, then biopsy is there. That's an option as well. Now, the second question, I think you were asking about other ancillary features for LI-RADS M. Is that what you were asking about?
Yes, if there are some ancillary features that can help to differentiate the lesion on the LI-RADS M categories.
Yeah, there are ancillary features, and they are listed. They tend to be stronger for establishing hepatocellular. So, for example, if there's fat in there, then it's going to be LI-RADS 4 or 5, not M. Capsule, that's going to be, LI-RADS 4 or more likely 5. Targetoid appearance is LI-RADS M. But keep in mind that I don't think we're ever going to reach perfect specificity for cholangiocarcinoma. Targetoid configuration, whether it's enhancement, diffusion, or whatnot, is usually a marker of poor internal perfusion, where the outer part of the tumor is getting better perfusion than the inner part of the tumor. And that's common of multiple tumors throughout the body. And hepatocellular cancer is one of the exceptions, that generally it maintains a good, solid, effective blood supply, so it doesn't have internal necrosis and does have good internal perfusion, so it doesn't look targetoid. But then as hepatocellular cancer becomes more and more de-differentiated, it begins to resemble other tumors. So targetoid masses can be hepatocellular cancer. So I think we could be very good in being specific for hepatocellular cancer. And I agree with Claude, we want to get better specificity for LI-RADS M rather than LI-RADS 5. That is, get better specificity for cholangiocarcinoma. But I think it's going to be a bit of a Zen thing. We may not get perfectly there because HCC can develop into so many different things. Now, diffusion-weighted imaging, a lot of hepatocellular cancers are bright on diffusion, but most of them are really T2 hyperintensity. So if it's true, strong, restricted diffusion, it's more likely with cholangiocarcinoma. There's a few other ancillary features, but it's probably the biggest challenge. Probably the most important thing is keep LI-RADS M in mind. Don't be too tempted to see arterial phase hyperenhancement washout and just stop there. Think about LI-RADS M and decide whether there's anything else about it that makes you doubt hepatocellular cancer. Did that help address your question?
Yes. Thank you very much for.
Thank you. Thank you. So another buonasera to Federica. Federica, you want to say something?
Yeah, regarding Roberto's first question and your answer, actually our approach in Palermo is that, so our gastroenterologists usually do for these LI-RADS 3 or LI-RADS 4 lesions an MR or CT, so first MR or CT and then ultrasound, so they switch each 3 months CT or MR, and after 3 months ultrasound, and then again a CT MR, so that the interval between each CT MR is 6 months. Do you think this is a good approach, or should we be for LI-RADS 4 more strict and ask for obligatory MR each 3 months? We do this because in Italy we have public healthcare, so it's a bit different compared to US. But I think, as you said before, it could be a reasonable approach. But I would like to have a more detailed. If you think it could be doable to do CT/MR each 6 months and ultrasound each 6 months. I don't know if it's clear my what I said.
Yeah. Well. I think it's very reasonable to consider switching modalities. There's pros and cons to that. And I'm not sure if you were asking if doing all 3 exams within a 6-month interval. So at the next 6 months, they would have had a CT, an MR, and an ultrasound. Or if you're thinking about coming back for imaging in 6 months, but doing it with a different there's pros and cons to repeating the same exam versus switching. Certainly when you're comparing 2 exams, if the purpose of the exam is to see interval change, that's most straightforward when you do the same exam. If the purpose of the other exam is to get complementary value, then you'll get more complementary value from doing a different exam. So when we do 6-month interval imaging, most likely we're going to be doing the same imaging method to look for interval change. When we do more rapid imaging, there's a higher likelihood we may switch method to get the added complementary value. Does that help address your question?
Yes, it does. Thanks.
So thank you very much. Grazie, Federica and Roberto. Dr. Serlin has a last question here.
Oh, well, I didn't realize it was the last question, but Don, I was wondering if you could comment a little bit more on the issue of stability, and in particular, sorry, there's a police siren outside my house. Hold on one second. Okay, I don't know if you guys could hear that or not. They weren't looking for me as far as I can tell. But anyway,
yeah, I
the
was
question.
saying, are you okay? Did you do anything wrong?
Well, they left, so I think I don't think they were looking for me.
Okay.
When you're looking at stability, Don, I was wondering if you could comment a little bit on how you would handle the following situation. An observation is stable in size, but it's changing in its imaging features in some other imaging feature other than size. How would you handle that sort of situation?
No, that's a great question, and that sometimes comes up. And it depends which features. It's a stepwise thing as you think about it. So you're showing that it's stable in size, but it looks different. So the first question is, does it look different for technical reasons, or does it look different because you're convinced it really is different? And so that's the question. Obviously, you don't always know the answer to that, but that is what you're trying to decide. So if it looks different, but it might be technical, but it still may be that it looks different, and before it was a LI-RADS 3, but now, let's say it didn't have washout, but now you're seeing washout, so now you may want to call it LI-RADS 5. So even if the lesion didn't change, so sometimes I'll say, based on the current exam, this is now a LI-RADS 5, although no definite change compared to the prior, allowing for technical differences. Now, another scenario where you are convinced that it really did change, let's say you have a 3-centimeter mass and it's homogeneous and somewhat nonspecific. Now you have the same 3-centimeter mass, but now there's some hyper-enhancing nodules inside. This could very well be foci within the tumor that are dedifferentiated, nodule and nodule appearance. So this would greatly elevate your confidence that it's malignant change, even if, as you previously defined it, the size is the same. Does that help address, or is there anything else you'd like to add to that?
Yeah, no, Don, that was terrific. I guess the only thing I'd like to add, but this is anecdotal on my part, and I'm curious to see what you think, and Victoria and Khaled and anyone else who would like to pipe up. But in addition to the changes you've described, another change that I've seen periodically is the loss of arterial phase hyperenhancement. It's not something I've seen that often, but it's something that I see periodically where there's an observation, it's a LI-RADS 4, or maybe it's a small LI-RADS 5. And in the United States, as you know, Don, but maybe some of the people listening here don't know this, in the United States, we're often waiting for a LI-RADS 5 to get to be bigger than 2 centimeters so that the patient can get the exception points that Don is talking about. So it might sound odd, but we're often literally following nodules that we know to be cancer, and we're not treating them. So we're following LI-RADS 5s. And I've sometimes seen them lose their arterial phase hyperenhancement. Very anecdotally, I have not done any research on this, but when that has happened, those lesions often end up being quite aggressive. And I've seen a few cases like that over the years where they exploded. And so my feeling is when I see a lesion that changes imaging features, even if it changes imaging features in a way that might make the lesion look less worrisome, that does not reassure me. And I often get very worried about lesions that are changing their appearance, even if they're not changing in size. Even when the change in appearance is one that you might think would make the lesion look more benign rather than more malignant. I'm curious, Don, whether, what has been your experience with that phenomenon, and also what others that are listening in might think about that.
Well, it's a very interesting comment, and in a way it makes some sense because aggressive tumors often have more ineffective arterial perfusion. So it could be that within a well-defined, well-differentiated HCC, there are components within them that have not gotten big enough to take over the lesion and expand it, but may be changing it. The problem I have is when you see stable size and arterial phase enhancement is different, it's often difficult to be sure that it isn't a technical difference. So I don't know if I recall the exact, if I recall seeing a case of the exact scenario you described, but it certainly makes sense. And I think those anecdotes are worth looking into and documenting to see if they're, making some sense out of that. A long time ago, we did a study where we looked at sub-centimeter foci of hyper-enhancement only seen in the arterial phase. And we looked for change of characteristics, growth, and whatnot. And actually, the only thing that made a difference was, in eventual outcome, was change in size. So in that treatment, we didn't happen to see the scenario you were describing, but it's certainly an interesting observation.
So thank you very, very much, Dr. Mitchell. Thank you, everyone who joined us, and Claude also for the comments and the questions, and everyone for their participation. Last comment here and the question about this liver parenchyma in the background of the slide of Dr. Mitchell. It indicates your passion and love to the liver, right? It has the nodules, but it didn't show the hepatocarcinogenesis. I would like to see the difference between regenerative, dysplastic, and HCC on the background here, Dr. Mitchell.
Yeah, mostly I was looking for something to provide color and texture, but not take away from the text and examples. And I felt like I couldn't come up with anything better than this.
That's a great, actually.
But Don, just to be clear, this is not a biopsy of your liver, correct?
Absolutely not. It's
Okay, that's great. So thank you very much, Don and Claude and Victoria and everyone who joined us. Buonasera from to Italy, and what is that again? Buona tardes to our colleagues in Colombia, and Msa al Khair to colleagues in Egypt and Saudi and Middle East. I have my